So just as introduced, we'll be talking about enhancing research recruitment among diverse populations. Thank you so much for the introduction. So again, my name is Chelsea. I'm a current first-year medical student at UCSF. I worked my 3 gap years at Children's Hospital Los Angeles under the Biobehavioral Pain Lab with the anesthesiology and critical care medicine team. And so through my experiences, I've really seen how participation in research is not just about awareness, but it's also about trust. And so today we'll talk about how the lack of diversity in research plays out in cystic fibrosis. And these are just a couple pictures of the research I've done and presented on, and then my last day at CHLA, which is a very fond memory of mine. And I also just want to acknowledge that as someone new to the cystic fibrosis space and working alongside CFRI, it really is an honor to be a part of these conversations and just learn more from everyone here. So my goal today is not to provide a comprehensive lens about diversity in research, but just to build everyone's toolbox and understanding about thinking critically when reading research, thinking about its benefits and harms, and what we can do moving forward. So I just want to provide some context and begin some level setting. So I like to just talk about the different types of research. So in an umbrella overview, there's 3 types of research. So we have basic or bench research, as some people refer to it as. We have translational and also clinical research as well. So basic or bench research begins kind of like those building blocks of how things work, and it's typically done on a cellular level. So for example, studying the underlying mechanisms of gene mutations in the CFTR gene that leads to cystic fibrosis would be an example of basic research. Translational research is the bridge kind of between basic and clinical research. So for example, since the discovery of the CFTR gene, scientists have worked to identify compounds that could improve this gene's function, leading to drug discoveries like ivacaftor, sorry, the drug pronunciations are getting me. I apologize, but clinical research also allows for the studying of these potential therapies like this drug, so to learn more about its safetiness and effectiveness. So when we think about these different types of research, and especially within clinical research, who do you think is typically the largest studied population? I think Hannah's going to pull up a poll for us and just want to kind of gauge the audience's understanding so far. I'm not sure, Hannah, if I can see the results or how it happens.
Yes, so we have the results coming in. I can see, I'm just going to give it 1 more minute as people are selecting their answer, and I will share
Perfect.
the results. All right.
Okay. Let's see. Okay, yeah. So as expected, as I thought. Sorry, let's see. Okay, there we go. Yeah, so building on that question, so yeah, when we do think about the populations that tend to be most represented in research, especially within clinical studies, we often see that white participants make up the largest portion. And this matters in CF research because participation shapes not only what we know, but also who benefits from that knowledge that we gather from research. So just like we learned in the previous slide, research is building on each other. So the previous step builds on the next step. And so certain diagnostic tools or treatments today might not fully represent the full CF community, and those results might not apply as equally to everyone living with CF. So historically, CF has been thought of and taught to clinicians and other health professionals as a disease that primarily affects white individuals. And that means that a lot of diagnostic tools and genetic panels were developed with those communities in mind and more common in those communities. So here in this graph, we see that impact. So this graph is from McGarry and others, and it shows the detection rates of cystic fibrosis across different racial and ethnic groups. And you can see that detection rate is much higher among white participants compared to a lower detection rate in Black, Asian, and Hispanic groups. And especially pharmacology trials don't typically represent either race and ethnicity, or they're completely absent in those demographics. So what this can mean is that some people might experience delays in diagnosis or even miss the diagnosis altogether, simply because these genetic panels and tests weren't designed with this diversity in mind. So when we talk about enhancing diversity in research and improving representation, it's also about improving accuracy and effectiveness and equity in that care as well. So thinking to recruitment in underrepresented groups, we have to also recognize why is participation low, and much of that starts with history. And so events like I'm sure we've heard is about like the Tuskegee syphilis study, where Black men were deceived and denied treatment, which not only had negative impacts on the Black men that were studied, but also their families, such as women and children who were consequently infected as well. There's also Henrietta Lacks, whose cells were used without their consent, and to this day there's still justice being fought for them as for their family, and then decades of excluding women and minorities from research. And so this all shapes how these communities might view medicine and science. And for cystic fibrosis, this also plays a role in research in CF as well. So this narrative that CF is a white disease still continues, and that misconception meant that many clinicians didn't test for CF in patients of color. And so families might have not been aware of CF research as relevant to them. And so even now, some campaigns are still centered around CF around white individuals. So this is a screenshot of just a Google search of cystic fibrosis campaigns. And so we still see a lack of diversity in the campaigns, even just from a quick Google search. So both these histories of exploitation and also exclusion are all creating barriers to trust in research. So I just want to talk about CF research today, and about the equity challenge that CF research is facing. So we know that CF affects people of every racial, excuse me, let me change it. Okay. Of every racial and ethnic background. And so as shown in this graph, we see that there's an increasing number of individuals living with CF from non-white populations from 1987 up until just 2 years ago. And so I think this signals to me, and I hope it relays to you, that there's a couple things, that there's a growing population of individuals with CF that have historically been under-recognized, underdiagnosed, and underserved. And so there's also, for research, signals that these diagnostic tools or even the treatments that were developed with the majority white population in mind are not fully reflective of the increasing diversity of people living currently with CF. And one of the key mechanisms behind this is genetic diversity within these populations. And so in this figure, we see that non-white individuals living with CF have the largest gaps or unknowns in the disease-causing variants in CF. So with Asian and Black individuals with the greatest proportion of an other unknown mutation. And so there are also implications for this as well. So this can go into diagnosis. So if the panels that typically look for common variants only are looking for common variants, there might be misvariants, and that might be prevalent in other groups, such as Black populations or Hispanic populations. This also limits eligibility, since for certain therapies, certain therapies are only possible with specific variants. And so if certain populations have variants that are understudied, they may be less eligible for these life-saving therapies. Additionally, research inclusivity will lead to less generalizable results, since these other variants are not being as studied as well. So if we're keeping in mind this increasing diversity and the amount of unknown or more rare variants in non-white populations, I invite us all to like reflect about how research can change moving forward. So is research really measuring what matters for all these groups? Are we asking the right questions in research to design to capture these differences? And are we including the voices and the participants from these groups that might be most affected? So this notion that one size fits all doesn't really work when these variant frequencies differ by group. So why isn't research kind of, reflecting that same diversity? So this is not comprehensive, but just thinking about some of the barriers to participation, there's some structural barriers, cultural barriers, and also just practical barriers. So structurally, CF care research centers might be located in less diverse areas. And so the communities of color living with CF might really struggle to get to those or connect with those research centers. So that can make it very logistically difficult for families and not even to think about, time or financial costs, such as taking time off work to make it here or transportation or childcare for their family. So those can all be really significant barriers. Additionally, culturally, awareness of cystic fibrosis can be lower in some non-white communities, and the lack of health literacy around or in these communities as well. So that's in partially maybe because of the historical framing of CF as a white disease, but also thinking back to the historical harms that we talked about a couple slides ago. So that definitely has lasting impacts on communities, and that mistrust can extend into new research if research teams aren't making that intentional plan to build relationships within these communities. And then also practically, sometimes research is just not designed and they unintentionally exclude people. So that can include study materials, such as them not being linguistically available for certain communities or tailored culturally for certain communities. And even the research team that some participants will interact with, if they don't feel represented in the research team, they might not feel as welcome or willing to be a part of the research at hand. So maybe from your earlier reflections, you thought of a few ways we can enhance diversity in research in CF, and hopefully a couple of them might be found here. So these are just some thoughts about ways to build trust in these communities. And so first, partnering with community leaders. So whether that's within, churches or local advocacy groups or patient organizations, sometimes bringing research to spaces that have already built trust might be the best place to start. And these partnerships can help allow communities to kind of lead that research and allow them to shape the message, the approach, and the research questions themselves, since they may know best and speaking from lived experiences. And then also recruiting and training diverse research staff. So people, as I said earlier, people might be more likely to participate when they see themselves reflected in the teams that are working alongside them. Additionally, designing studies with participant feedback in mind. So remembering that we're serving a population and thinking to and keeping in mind what barriers they might face. So trying to reduce travel requirements or offering flexible visits for the research, or even using things like telehealth so that people can connect more easily and more frequently if needed. And then also which isn't written here, but something that I thought of was just also returning back those contributions. So something that during my time as a researcher, a lot of times I would think about, like, how do the participants get this information? How do they get to learn about the conclusions that we found? So I think finding ways to close the loop so that participants kind of know what those results might be and how that might have implications for their own selves and well-being as well. And then lastly, working with CF with CF initiatives. So working with the groups such as CFRI that does amazing work now, and initiatives that have already started, like DEI clinical trial work groups. So not necessarily building from scratch, but working with these partnerships that have been long established and have worked with these communities is also a great way to build trust as well. And so with that, I wanted to, give us a chance to actively practice some of these ideas by listening to our panelists, which I'm very excited to hear more from and just learn about their own lived experiences in participating with clinical trials and more. So thank you so much for your time and giving some level setting. And I'd like to pass it off to our panelists.
And yes, and so if Nayeli, you would start us off, that would be wonderful.
Okay, hi. Hello. My name is Nayeli Ochoa. As mentioned earlier, I am currently a student at Cal State Fullerton. I am studying business administration with a concentration in general management. I am currently in my 4th year. So if all goes well, I will be getting my bachelor's in the spring of 26. Thank you. I wanted to start off by talking about my background and my diagnosis for CF. I was diagnosed at 4 years old. I was diagnosed at 4 due to a later, I guess, diagnosis. I was born right before the California implemented the CF newborn screening. So I didn't make the cut to get diagnosed sooner. And early on in my childhood, I struggled with digestive issues and a lot of pulmonary issues. So these factors raised concerns for my parents. And from there, my mom fought very hard for me to be seen by someone and to be treated for, first off, my digestive issues. I started off in GI. And from there, I just kept going from one GI doctor to the next, saying that it was lactose intolerance, or that I probably had what was the other word that they said? I was just, sorry, I'm blanking out. But from there, I saw a GI doctor, and they referred me to a pulmonologist. And it was there that I got my diagnosis at 4 years old. And being a Hispanic Latina, my pediatrician later told me or mentioned to me that they probably they diagnosed me later on because they didn't think that I would have CF, because CF wasn't common in people of my background. So that also prolonged my diagnosis. And now we'll be sharing some research that I've participated in. I've participated in sputum collection, bacteria breath analyzer, stool samples, sleep quality tracker, and the bacteriophage. Despite it being very time consuming at times and draining, I felt very motivated through my family and my CF team to continue to participate in research. Growing up in LA, I was able to see many diverse groups in my CF center. I grew up with a very diverse group, so I was able to see more people with a similar background as me, and I was able to connect better, and I was able to see that my family wasn't the only family going through similar situations. And my CF team was very understanding of that, and it was just very comforting to know also that, they also spoke Spanish, and they also encouraged me to participate. And now I have a brother also with CF, so that is another factor in why I continue to participate in research because I know that although right now I don't qualify for CFTR modulators because of my mutation. Um, it's just it also motivates me to want to continue to participate because eventually it not only may help myself but other CF patients. And I also consider my brother a motivating factor in why I continue to participate because I know that he's gonna need someone to look up to, and I want to be that person for him. And my family has always been there for me when I'm participating in research, which has also been something that I felt really grateful for. And I've never felt like pressured from my CF team to always participate in research, but they had that little gentle push, which also was something that I needed and something that definitely motivated me and helped me to want to continue to participate. Um, Another thing in participating in research is that it's helped me have a better understanding of CF and a better understanding of CF and diverse groups. So that's something that I've gained also from research. It's expanded my knowledge in CF. So that's something that I want to continue to participate in because it's helped me in those areas. And I just, sorry, I want to say that I'm just so grateful to be part of this CFRI meeting, and I that's pretty much it. Sorry.
Thank you so much, Nayeli, for sharing that with us. That was very beautiful to hear from. I'll go ahead and pass it to Devanshi to go ahead and speak on her first.
Thank you, Chelsea, and thank you, Nayeli, for sharing your story. As Siri mentioned, I was born and raised in India, and I was diagnosed with cystic fibrosis at the age of 19 in 2021 when I moved to the States to San Diego for college. I was diagnosed later in life despite having symptoms growing up. I am currently applying to graduate schools in clinical and health psychology. Back home in India, CF wasn't something most physicians even considered. And if they did, the genetic testing was not widely or easily available. So I believe that when we talk about enhancing research recruitment among diverse populations, I think it's important to recognize that diversity isn't one-dimensional. For people from underrepresented ethnic backgrounds, late diagnosis is even more common because CF is still seen as a Caucasian disease. The genetic panels used in many countries and even in the US until recently were built around mutations most common in Caucasian populations. So when you're diagnosed later, you're not only dealing with more advanced illness, you're also being systematically excluded from research that could change your life. Something I have noticed in cystic fibrosis research that a lot of clinical trials automatically exclude people who are relatively sicker. They focus heavily on quantitative measures like lung function and often set cutoffs, only enrolling participants with 40% or higher FEV1. The reasoning behind that approach is usually safety, data consistency, where researchers want a stable, controlled sample to minimize risk and make results statistically clean, which makes sense. But in practice, that kind of gatekeeping creates a huge ethical and equity gap. It systematically leaves out the very patients who could stand to gain the most from these groundbreaking therapies. People with more advanced disease are not less deserving of innovation. They're actually often the ones who have waited the longest for it. And when you layer that exclusion on top of racial and ethnic disparities, the gap only widens. People of color are already more likely to experience delayed diagnosis, have very fewer specialty clinics nearby, or face barriers like insurance, language, or the most limited awareness of CF in their communities. So by the time they're diagnosed and even eligible for research, they might fall into that sicker category and then get turned away again because they don't fit the numbers. So the system ends up excluding them twice, once because of social inequities, and again because of this rigid clinical trial criteria. And that's why I would say enhancing diversity isn't just about who we recruit, it's also about when we reach them. Because earlier screening, inclusive genetic testing, and culturally competent education can help make sure people of all backgrounds are part of the research journey from the start. Additionally, I think we need to give clinicians and research teams more flexibility to make judgment calls. Because if a study is safe and the potential benefits are significant, then patients with advanced disease, regardless of background, should be given that opportunity. True diversity in research isn't just about who gets recruited, it's about who gets left out and why. And as for inclusion, it goes far beyond eligibility criteria. It's about trust, awareness, and access. Because many families from racially and ethnically diverse backgrounds are not reached by the same information networks that others are. They might not even know clinical trials exist, or they may hesitate because of historical mistrust, language barriers, or previous experiences where they did not feel represented or respected. And the comfort comes from transparency and trust. As patients, we want to know that the study team truly understands our situation, not just our lung function number or other quantitative measures, but our day-to-day challenges, our health fluctuations, how CF affects us beyond the clinic. That trust also means showing up consistently in communities, not just when, they need participants. It means creating a culturally relevant outreach, translating materials, engaging with patient advocates who already have the community's trust, just along the lines of Chelsea mentioned as well. Because representation within the research team also matters deeply. Because when patients see people who share their background, they feel a sense of belonging in that space. And it helps so much. And at the end of the day, enhancing diversity in research isn't just about checking boxes, it's about creating a culture where every patient, regardless of race, ethnicity, or background, feels seen, heard, and valued. Because when our research reflects the full spectrum of people living with cystic fibrosis, the science becomes not just stronger, but more equitable. And that's the kind of progress that benefits everyone. Yeah, that's it. Thank you.
That was beautifully said and very powerful. Thank you so much, Devanshi. I'd like to pass it over to Dr. Maria Bordella.
Thanks for inviting me. This is my second time joining this group. Last time was speaking to the Spanish patients about clinical trials. And that was pretty interesting because I've been in America since I was 5. So my Spanish was, I think I speak pretty well, but I learned it more from watching novelas with my grandmother. But I think being here today and talking and listening to your stories about research is really powerful. I think that the two perspectives that you guys brought, one of being diagnosed late, happens a lot. It's happening less now because we have newborn screening in all the states of the union. The problem is that it's not uniform. So not every state tests for the variants that may be in the minoritized populations. So we're trying to work with every state to get genetic testing on a more equal level so that patients don't get missed, especially the people that are non-white, that don't have the Delta 508, so that have, the rarer variants that may not be in those panels. As far as participating in research, I agree that at least in New York, I can tell you that we are from a diverse population. Our center has patients from all over, and from many backgrounds. So that's what prompted us to kind of study more how to involve people who are not just white in research. And we looked into a lot of the things that we were doing to try and assess in our one center how we could make it better. So even today, I had a discuss with, so in New York, we have, and I don't know if in California they do, they have collaboratives that we set up. So we have groups now between CF centers that got together to discuss research between all of our centers, and we involve different states close by. So we have people from Connecticut, centers from Connecticut, centers from all the centers in New York. And there are a number of centers whose population who are not eligible as a center to do studies that are sanctioned by the CF Foundation. So the Therapeutic Development Network, which is, I don't know, it's been around for more than 20 years. It started by assigning certain centers in the country to do research. So you had to apply and become a research center so that all the trials that came through would be funneled to these group of people that are in the network. But there are a number of smaller centers in the country who are not part of that. So these collaboratives that we have now are including those centers so that the patients at those centers can also be able to participate in research and know what the research is that's going on in their area. So as far as our center, we have a diverse group of people, and we're very unique in a way because our research coordinators and our research team is part of the clinical team, so that this team knows the patients. Like you were saying, it's not just coming to the center and being, talking about research, but they know the patients from birth to adulthood, and they're able to collaborate with them and know where they're coming from and know their stories, so that when they do bring up the research part of this, what research trials we're participating in, the patients have confidence that the research team knows them well enough and knows that, what they're offering them is, is good for them in terms of the research trials. I don't want to be the only one talking, but I want to see what other people think about this and kind of open it up for others to discuss more. And
I'll ask a question. Well, there are other diseases like sarcoidosis, which is more prevalent among African American women. And the sarcoidosis group did a study about clinical trial participation, because the same issues coming up and historical distrust. But what was interesting is there were all the things we've talked about, but one of the things in all their polling that came out as one of the strongest factors is that they were not asked. And I think that's something really important within the CF centers and the research coordinators, whether there's a self-auditing going on, some inherent bias that is keeping them from even asking. And so then, all the reasons that are highly legitimate and true in terms of why there would be distrust. But there's another component, which is people not being asked. So I'm just curious, like Nayeli, your experience. I know CHLA has such a great track record for inclusivity in clinical trials, but were you, for all of you, Devanshi, were you asked by your research coordinators regularly? How did that come about, your participation?
Well, speaking on my experience, as mentioned, it's that my CF team knew the background where I was coming from because I've been there since I was diagnosed. So my CF team knew my situations at home, and my again, ethnic background and where we were coming from. And when we were approached about research, about participating in research, it was first brought up in like conversation, giving us a little details about what kind of research potentially we could participate in. And being this, sorry, because my mom is very involved in my care. She was very interested, and she was the one helping me branch out and learn to speak up for myself. So she was the one asking more so the questions of like which researches that I can participate in or that would be a benefit to not only myself, but my brother, as mentioned. And during that time, my mom was the one that was helping me get a better grip of the ropes. And as little by little, I started participating in, smaller research. Then from there, I myself was more interested in participating in in more research. So my team talked me through some of the research that I participated in, and they, explained in detail what the research is for and what areas will it benefit. And they've explained to me too, not all research is gonna always be of benefit to me, but if it doesn't help me, it could potentially help someone else. So that's something also that my CF team would always bring up to me. And research was always encouraged in within my CF team and within my family. So I had no problem participating in research. I was always interested to learn more, and I was always interested to help. And if there was any way that the research would lead to, eventually the goal one day, finding a cure, then if I can help in any way, that is what also motivated me and what helped me in my journey in research with my CF team.
Devanshi, were you approached?
So I think when I just newly got diagnosed in 2021, a bit after that, I was approached for some kind of inhaled therapy research study, but at that time I had to refuse because I was like, there's so much, this is all so new. I'm navigating so many things at one time, my college, these new breathing treatments and all that stuff. So I had to deny that. But currently I'm in a research study where they take sputum samples and so yes, but even in the beginning when I was approached, they were very patient and they explained everything in detail and they were very accommodating, like, okay, this is how it's going to affect, or this is how it's going to, like they were very detailed with everything. So I was very fortunate enough to get all the answers to any questions I may have. So yeah, they were very patient. It was nice. I had a good experience.
So I think that's great that CF teams approach the patients. When you were saying that there are certain trials that you can't participate in because of your FEV1 being under 40, and that's true. A lot of the modulator therapies, most of them won't. They have certain protocols that you have to follow. They sit in a room and create these protocols. They come up with the things that they want the patients to fit into to be able to sign up for the clinical trials. And one of the so there aren't that many trials that you can enroll in if you're especially the modulators and all of those, because they want to be able to get through the trial. And then if you have patients that have confounding problems that could be blamed on the treatment, and it may not necessarily be, it may be because you got sick just because of your FEV1 being low or your other comorbidities. They don't, like you said, they don't want to murk the data, because then the FDA will not approve these drugs, if something happens that's not related to the drugs themselves. So they are trying to get them through as fast as possible for people that need them. So once they actually set up a compassionate use for before the FDA approves these drugs, sometimes you can get them ahead of time for patients who really you have. I've had many patients that I wanted to start these drugs on right away that were not approved. So you would go through a compassionate, application and get the drugs to the patients earlier, knowing that they were going to get approved at some point. So there's ways to do that. Also, because people have these rare mutations, you may be one of 8 people or 10 people that have that mutation or that variant, and they're not going to study these drugs. So I don't know, but we have therapytyping, which we use. And everyone's saying, yes, a lot of people are using therapytyping to, study the cells in the laboratory, and they test all these modulators. And we've been able to put some of the minority patients into those, give them those medications and make them better just from trials from therapytyping. So you got to find a lot of ways. So that's another way that patients participate in research. They come in, that's a research protocol where they scrape the cells from your nose, you send them to the lab, and they check to see if your variant works, with the modulators that are out there. So we have to find different ways to kind of get everyone involved. I was talking to my research team this morning about what we can do better. And Melanie, what were you saying this morning? Because she's our newest research coordinator, so she comes from a pretty good viewpoint. So it's good, right? What did you say?
There was like a lot of things that were also mentioned in the PowerPoint too, just kind of thinking about how the patient feels, like I think from like a Hispanic Latina standpoint of kind of that barrier of transportation, that barrier of like when you talk about a research trial, you'd want to hear money because it's like, look, I'm taking the time out of my day to go to do this when there's so many other things I need to do. So money is like a huge thing when you present that as well. It really helps. Another thing too is like children when they have their kids, like if they need to come to a trial, like bring your kids if you can, like if it's a trial that allows that and we're not doing medications on you at the moment, bring your kids. So it's like a way of doing both at the same time so you don't have to compromise so much. So kind of lowering that in a way and trying to like bring down the barriers too. So transportation, all that gets covered. So making sure that that's clear to the patient too, that you don't have to worry about how you're going to get to us and how you're going to get home afterwards. Like we have that covered for you and that we work with their schedule too. So that's just how I see it for all patients of all diversities. We all have our own issues, but it helps when you point out those things.
It's true about, like now the trials are becoming much more smaller and because we're doing phase 1 mRNA trials. And so they're only enrolling one patient at a time. Then they stop the trial because something happened, then they have to review it. So those patients that we enroll in these trials have to spend a lot of time and it's a lot of, blood draws and a lot of, time sitting in the center to do these trials. So the sponsors who run them know that. And so they provide hotels in the area because patients have to come in every day sometimes to get the medications. So they'll give them hotels, they'll give them Uber, they'll give them, dinner, lunch, whatever we need to make you as comfortable while you're sitting in the, in our research room doing these trials. And that helps knocking down a little bit more the barriers of research. And some of them are very complicated trials. Some of them require bronchoscopies, for example. And a lot of patients we have one patient who, this African-American patient I was talking to about, he fits the criteria, but he does not in any way want to have a bronchoscopy because he had one in the past and he had a terrible experience. So trying to talk people through, maybe this is your experience then, but taking the time to kind of explain a little bit more, things like that, just having a conversation with the patients and getting them more comfortable is one of the things that we need to do, and explain to them what type of research is available. We were talking about creating a list that we would have in our research rooms or in our clinical rooms when the patients come in and say, talk to us about research, and we can tell you, if we don't run the trial at our center, this is where you can go to do these trials, and give them that kind of information. And I speak Spanish and Melanie speaks Spanish, so we can talk, freely to the parents of a lot of the patients who the patients understand English, but their parents don't. So to get them involved and to understand research, it should be spoken to in their language. So, that's really important. I don't know if Eleanor has anything. Eleanor is our genetic counselor who knows about every variant that's out there. And she is the best resource we have for that. And she's on all the newborn screening panels, and is the one who finds out if your variant will do anything with the therapeutic or whatever we can do to get drugs and medications to the patients.
Yeah, we've definitely been fighting the good fight to get access. We've gone to court even to get Medicaid to pay for access to modulators off label. And this conversation has been so fantastic, and I'm just happy to be sitting back and listening. I'm thinking about all our decades of doing this, Dr. Berdella, and it is sometimes it's easy to just round up the usual suspects, right? You've got patients who have historically, they've come to, they're compliant with their care. They've been in research before. It went well. It is very easy to just keep going back to the same people over and over again. And, it's important that we do the hard work to bring in more people and get that diversity. And so I'm very grateful to be working with Dr. Berdella and now with Melanie, who can, open new pathways to be able to recruit people of diverse backgrounds into our studies.
It is true. Like when you go through the protocols and then you go through the you look at the amount of patients you have, and then you say, oh, we have 10 patients that fit the protocol that we could offer this trial to. But then everyone starts drilling down. Well, that patient's not compliant. They never come to clinic. Why would they, do well in a clinical trial? And this one has this and this one has that. So all these issues start to pop up, and then you start you're left with 2 or 3 people, and that's not the right way to do it. I think that, whatever you think the patient is, we just offer it to the 10 people and say, hey, this is what we have. This is the trial, and let them kind of mulch it and decide if it's something that they can actually participate in. Instead of us kind of deciding who to choose from the 10 people that we have on the list. And I don't know if anybody else does that.
I would say the other thing that does is, even if, patient 4 says, this isn't a good time for me to do that, but maybe the next set of trials will say, oh, I remember you spoke with me about it. I couldn't do it before, but now, my life, things have changed, and now I can do it.
And it's true, starting with a small trial, like a sputum collection trial, to make the patient more comfortable with research, starting with something small. Look, you can do this. I don't know how you did enzyme trials, because those are, you have to collect stool and you have to take the enzymes, and we've done those. And a lot of patients are like, I'm not doing that. But, they're easy kind of trials to be participating in, or the other clinical trials that are not necessarily medication ones. to start with so that people get more comfortable with participating in research per se. And then you can escalate it up, right, to other trials.
Yeah, I think Chelsea, you really laid that out so
Yeah.
beautifully about just building rapport and building
Mhm.
trust around the idea of research, and then being able to bring people into the fold when the time is right for them.